Then at 9:30 a.m. Eastern Time, it's a hearing on funding for the Nicaraguan Contra rebels, the subject before the Senate Foreign Relations Subcommittee on Western Hemisphere Affairs. That's followed by the remarks of President Reagan delivering the commencement address at the U.S. Coast Guard Academy in New London, Connecticut. Up next, testimony on civil rights and acquired immune deficiency syndrome before the United States Commission on Civil Rights.
Fine.
We got to have the presentation up
Yeah,
there.
I think that you're going to be able to see the slides pretty well without turning all the lights off. We just tested. I don't really think you need to turn all the lights off. There isn't anything in there that's going to go.
Not X-rated, huh?
It's not X-rated, and it's not going to get blurred if you... Yeah, you could leave the lights on. It doesn't matter. It's fine.
Go right ahead, sir.
Okay, Mr. Chairman, members of the Commission, what I'd like to do over the next several minutes is just very briefly outline for you some of the substantive issues in the AIDS epidemic. This is a diagram which is one that can really explain why there's much confusion in this country as to how many people will ultimately get AIDS who are infected. The closed circles are the real data, not projections from that data. And as of 1988 May, we know that approximately 30% of individuals who are infected with the virus who are asymptomatic, namely they feel well, 30% of them in 5 years will develop AIDS. What we don't know is how many of them will develop AIDS in 10, 15, 20, 25, and 30 years. And that's the reason why I have the open dots that either plateau or that have a linear curve. The best scenario would be that there's a plateau there, that you won't have any more than 40 or so % developing full-blown AIDS. The worst case scenario would be that it's a straight line, that sooner or later everyone who's infected will get sick from the virus. And preliminary data that we have on immunological function, namely looking at laboratory tests which give you subtle indications as to whether someone is getting a harmful effect of the virus, indicates in a study from the Walter Reed Army Medical Center that close to 90% of individuals within a period of 3 to 4 years will have some form of deleterious effect of the virus, even though they remain completely asymptomatic. So although this doesn't give us the answer to that question posed on that slide, it strongly suggests that unless therapeutic intervention comes in, that you would have virtually everyone who's infected with the virus over a period of whenever, 20 years or so, will ultimately develop the disease. That's why it's imperative to identify and counsel and treat individuals if, in fact, treatment of individuals who are asymptomatic proves to be effective. And as I mentioned, we don't know that yet, but the studies are being conducted. This is a breakdown of the seropositivity in the United States, and I show it to indicate to you that the prevalence of infection among individuals who practice certain risk behavior varies greatly. It varies greatly among individuals, and it varies greatly depending upon where in the United States you are. For example, if you're a homosexual man in San Francisco, there's greater than a 50% chance, if you've been practicing high-risk behavior, that you're infected with the virus. If you're, for example, in a small town in upstate New York, it may be closer to 10 or 20%. IV drug abuse is the same. If you're from Newark, New Jersey, or Miami, there's a 70% or so chance that you're infected. If you come from the central part of the United States that doesn't have much interaction with the Newark, New York, Brooklyn, South Bronx, Miami access, the chances are much less that you'll be infected. Spouses of infected males also varies. And then I think the last 2 lines there give us some important information, and that's what I'm going to address now. A question that is often asked, and the public is very interested in this. What is the prevalence of infection in the general population, and what are the chances of the infection actually running rampant in the general population? We learned 2 things from our broader surveys. One is among blood donors, people who donate blood to the Red Cross or to their blood banks, and the other are military recruits. blood bank donors exclude, by their own will, individuals who are male, homosexuals, or IV drug abusers. So it gives you a good cross-section of the population excluding IV drug abusers and male homosexuals. And of that group, it's been consistent over the past 2 or 3 years that less than 0.02% of the general population is infected. However, the data from the military is somewhat concerning. And that is that if you look at sexually active young men and women, usually between the ages of 18 and 30s, who are applying for the armed forces, the broad number of the United States is 0.15%. So it's significantly greater, at least 5 times greater than the general population. But of great concern is that if you look at various parts of the country, the pockets of infectivity among individuals who are not IV drug abusers or male homosexuals is very high in areas that are in areas of high IV drug abuse and very low in areas that are not. For example, if you're a young white woman in the central part of the United States where there isn't much IV drug abuse in Iowa or what have you, there's a chance of maybe 1 in 2,000 that you're infected. If you're a young black man living in the South Bronx, there's about a 1 in 50 to a 1 in 100 chance that you're infected, indicating that the pockets of spread in the general population heterosexually are focusing around the IV drug abuser population in places like South Bronx and Newark and Miami or what have you. And that's something that really needs to be addressed when one thinks in terms of how and where and when you're going to have spread into the general population, because the numbers from the blood donor pool indicate that in fact we're not seeing widespread entrance of the infection into the general population. Another very good example of this is this slide, which is taken from a report of the number of seropositive babies in New York State. And in almost 20,000 infants who were tested, you can see in New York City, 1 in 61 babies are born infected with the virus. 1 in 61. And the breakdown again reflects the distribution of IV drug abusers. It's greater in the Bronx and 1 in 43, less in Manhattan, a little less in Brooklyn, less in Queens, and much less in Staten Island, which is precisely, again, the breakdown of the IV drug abuser population in that city. And all that tells us is what I just mentioned to you a moment ago, that spread into the heterosexual population by heterosexual sex will occur through the IV drug abuser population predominantly, not exclusively by any means. And the infants, predominantly 75% of the infants who are born of 75% of infants who are infected with the virus or who develop AIDS will be of parents who are either infected or at risk for getting infected. So the chances, again, of an IV drug abuser mother or a mother who's the sexual partner of an IV drug abuser is the greatest risk for an infant getting infected. Now, why are we not seeing spread of the infection in the general population the way we're seeing it in Africa? And the reason is that there are 3 major factors that are involved in the spread of this infection sexually. One is the prevalence factor. Again, in the general population, the prevalence is still very low. It's high in the South Bronx among IV drug abusers. That's the reason why they get infected much more frequently than anyone in the general population, sexually. In addition is what we call the promiscuity factor, which is a bad word to use because it's judgmental. It really means the degree, the number of sexual contacts. In general, people in the United States are a relatively monogamous population, despite the fact that in the United States thinks they're generally a swinging society. They're not, compared to some of the other societies in which multiple sexual partners is part of the sociologically acceptable norm in society. And I'll mention that in a moment when you talk in terms of Central Africa. Secondly, other cofactors, such as other sexually transmitted diseases, play a major role in whether or not, if you get exposed to someone who's infected, that you will in fact get infected. So the greater the chance of having another sexually transmitted disease, the greater the chance of getting AIDS or getting HIV infection if you're exposed to it. This is a comparison of a city in Central Africa, Kinshasa in Zaire, where approximately 10% of the general population are infected with the virus, as opposed to 0.02 or 3% in the United States. Again, the prevalence is very high in that country, and that's the reason why you're seeing the spread of infection. Now, this is a picture of the AIDS retrovirus, which we call the human immunodeficiency virus, budding off one of its target cells. Now, it's important to point out that this virus has a particular life cycle. Now, for those of you who are not familiar with this, I don't want to go through and explain this whole thing, but it merely shows on the right-hand part of the slide that when the virus enters the cell, it goes through a variety of changes where it uses enzymes such as reverse transcriptase to turn itself into a molecule that can enter into the genes of your own cell. Now, it can either stay there, or it can then reproduce itself and make another virus. When it stays there, that's what we refer to as viral latency. Namely, someone's infected, they're not actively making a lot of virus, and they can go on for years without getting sick. They can still be infective, however, because if those cells are transmitted to another person by blood or blood products, by sharing a needle, by semen or vaginal secretions in a sexual contact, even though a person is perfectly well, they still can, in fact, transmit the virus. And this is another schematic diagram of the virus on the right-hand side attacking a particular cell type. Now, I could probably spend 45 minutes with you going through the mechanisms of how the body's defenses are destroyed, but I think I could tell it very clearly on this next slide, which shows in a schematic way that the cell in the middle, which is essentially the conductor of the symphony of the body's immune system, and the body's immune system is the defenses of the body. The reason why you and I don't get infected and die from any common infection, and why we recover from viruses, is that we have a defense mechanism called the immune system which protects you against these infections. Somebody who's infected with the AIDS virus has that central cell, the helper-inducer cell, destroyed. That's essentially like removing the conductor of a symphony orchestra away and having the orchestra just play in a totally discombobulated way. Or it's similar to taking an important microchip out of a computer and then seeing the whole computer break down. That's the reason why individuals who are infected with the virus have a deterioration of their body's defenses, and they wind up getting a variety of opportunistic infections and tumors. These are the way the virus is transmitted. Still now, several years after we've discovered the virus, and 8 years or 7 years after we know that the disease AIDS exists, there has been no change in how we know the virus is spread. By homosexual or heterosexual contact, by blood or blood products, intrauterine to a baby from the mother, or needle sharing. The evidence for breast milk transmitting it is small. There are isolated cases of women who have gotten transfused during childbirth because of a complication, who then nursed their child and the child got infected. That's only 1 or 2 cases, so there aren't a lot of them. I just put it up there to be complete, but the 3 major ways are blood and blood products, sex, and mother to child. Now, there is no evidence whatever that the virus is transmitted by casual contact, and you've been hearing this for years. And when I say no evidence whatever, I'm talking about a variety of studies, and these are the titles of representative of many, many studies in the literature now, which studied the families of people who have AIDS or an AIDS-related complex, who live in the same house, share the same utensils, eat with each other, spend time with each other, use the same towels. There is 0 incidence of transmissibility of the virus that way. In addition, healthcare workers who have been taking care of AIDS patients, who have constantly them sneezing and coughing and what have you on healthcare workers, none of those have been infected except by direct inoculation of a needle that's contaminated when you're drawing blood from the patient. So the evidence that this virus is transmitted by casual contact is really 0, and this obviously has important implications. And then finally, this is again a slide of the life cycle of the virus. The arrows are shown in areas where they are vulnerable to attack by a number of drugs. For example, the drug that you've heard about, AZT, or azidothymidine, has the ability to block that enzyme right there in the middle, reverse transcriptase. We're working now in research capacity on a number of drugs that have the capability of blocking other components of the virus. Now, as you can see on the right-hand side, when there's latent infection, as I alluded to, there's nothing to attack, because the virus isn't multiplying itself. Only when the virus multiplies itself can you block it. The reason I bring that up to you is that when people ask us, when will you get a cure for AIDS? We're not thinking in terms of a cure in the classic sense when you come in and you wind up getting a pneumococcal pneumonia and your doctor gives you penicillin and he completely eliminates all the bacteria from your body. What we hope to do with drug development is suppress the active replication of the virus so that someone can lead a normal life to the point where whenever the virus starts to replicate, the drug can suppress it. Very analogous to insulin doesn't cure diabetes. But someone who's a diabetic, if taking insulin properly, can lead a reasonably normal life. Antihypertensive agents does not cure blood pressure problems, but it controls blood pressure enough so that you can lead a reasonably normal life. That's the kind of scenario we're aiming at in the development of drugs. And as I mentioned, azidothymine is a drug, the only drug now that is licensed for use in AIDS, which has been shown to be effective in prolonging the lives of individuals who are infected with the virus. This is just a diagram of the number of individuals in the NIH clinical trial groups which are being tested in clinical trials with a number of other agents. So although you've heard and read about AZT, and it certainly still is the best we have, there are a number of other drugs that are being tested right now that have some promise in the possibility of being used alone or in combination with AZT. And then finally, on this last slide, there are a number of approaches for vaccine development. Rather than go through all of these, which really have a lot of words which aren't of much meaning to you, let me say that there are two now vaccine trials going on in the United States. One right up here in Bethesda at the National Institutes of Health, and they're using a vaccine in what we call a phase 1 study. And that's to ask, one, is it safe to give, and two, does it induce an immune response? We're not even talking at all about whether it's protective, because vaccine development in AIDS is going to take years and years, even if we're lucky. In other words, before we have a vaccine that's available for widespread use, even if we're lucky enough to be testing that right now, it won't be until well into the 1990s, probably the mid-1990s, before we have one that's available for widespread use. And the reason for that are many, scientific, logistically, as well as the fact that the virus is spread by a behavioral component and not, for example, as influenza is spread, where you can determine in one winter season whether the flu vaccine is effective. It's going to take years to determine whether an AIDS vaccine is effective. So in closing then, there are a number of issues in AIDS, ranging from the basic research on etiology and pathogenesis up through the more practical and understandable natural history and epidemiology. I've described each of these very, very briefly, and I'd be happy to answer any questions on these if you have. Thank you.
I don't know how many of us are intimidated either by you or by your slides, or whether we're just scared, but I'm telling you that's very impressive. But I'm sure that my colleagues have, I have one or two questions, but I'll wait until my colleagues might have. You have a question?
I have a question, but I'll wait too.
No, you next. You got it. Your time.
Oh, thank you very much, Dr. Fauci. Let me just ask whether in anything you said to us in your presentation and the slides you showed us and so on, whether you and your statement here, as well as the work at NIH that you do on this issue, is influenced at all by the activities of lobby groups on various aspects of the persons who might be identified as highly probable to have HIV or AIDS. Have you been in any way influenced? I asked that. You might think that's a ridiculous question, and you may not have been here for the earlier panel.
No, I wasn't.
But there were all kinds of assertions that the public policies on this subject and the physicians who are involved in this issue, and you're a physician and researcher, is that right?
Yes, I am.
Have been influenced to take the positions they take in the policy debate by lobby groups who have certain positions. And it was always my understanding that wasn't the case, so I wanted to find out whether you feel that there's been some kind of influence from organized lobbies in your research, or to make you take a position on transmissibility, which would be otherwise, or not.
No, that's a very easy question to answer, and that is that the Public Health Service, of which the NIH is a part of, has approached from the beginning and still does approach the epidemic from a public health and scientific standpoint. it is totally preposterous to even imagine that any scientist that I know of, certainly not myself or the people that are involved in my own group as the coordinator of AIDS research in the NIH, would take a stand on how the virus is transmitted based on pressure from anyone other than the scientific evidence at hand. And the scientific evidence at hand is overwhelming in telling us how the virus is transmitted and how it is not transmitted.
Okay, well, let me ask you another question. The way I have seen what this commission is about in these hearings, since we're a Civil Rights Commission, I've sort of framed for myself the question of whether implementing policies based on the consensus in the expert medical scientific community at every stage in dealing with AIDS and HIV would discriminate against certain people in ways that are inconsistent with civil rights protection under our Constitution. Do you think that it is appropriate for me to rely on the judgment of the expert medical and scientific community in dealing with this disease or this epidemic or whatever as I go about trying to make my judgments about the civil rights implications? Should I rely on the judgment of the medical scientific community or not?
Well, I think you should. It depends on what you mean by the medical scientific community. Well, that's the problem. There's a lot of experts around, as I'm sure you're aware.
Okay, which one should I depend on?
They seem to grow and sprout forth as weeds in a garden. I think what you need to do is, when you talk to an expert, make sure the person is an expert in the area in which they're talking about. We often have an expert in one area, a basic science area, making a proclamation on natural history and epidemiology, or someone who works in vaccine development talking about molecular biology of pathogenesis. I think it's very clear that, for example, the ad hoc groups that the Public Health Service calls together when we do our planning for the kinds of research and things that are done, takes a good cross-section of people who are recognized experts in the area. If you listen to those people, I think you can probably formulate a sound civil rights policy, because civil rights would be compatible with the scientific data, and the scientific data, I think, in no way at all would discriminate against anyone. It's just important scientific data. You make your policy decisions based on what the data is. If for example, the virus is having a predominant spread among a particular group that needs special attention and help, I think that will be very, very clear. I mean, there are very good examples of that right now. It's very clear that right now the virus is spreading rather considerably among IV drug abusing population, and IV drug abusers have their own special problems. You can't just go over to an IV drug abuser and say stop using drugs. You've got to help the person. They're ill. You've got to treat them for their IV drug abuse, and then with that as a background, try and stop the spread of HIV among that population.
Do you think, are you the appropriate person to ask as an expert about whether contact carrier finding or case finding or contact tracing or isolation are appropriate ways of reducing the transmissibility of this, or is there some other kind of expert I should ask?
Well, I'm part of the Public Health Service Executive Committee, so I've been sitting in for years on all of the deliberations in this regard. Specifically, the most appropriate group for you to ask that of would be a representative of the Centers for Disease Control, the CDC. But I can tell you that there's universal agreement among public health service officials that testing someone and then if they're positive, isolating them, quarantining them is totally, one, not logistically possible, and two, incompatible with the public health service component of what you're trying to do. The Public Health Service has, and I can speak for them in this regard, in the past and still does recommend more widespread voluntary testing associated with counseling, both pre- and post-testing counseling, so that you might help the individual who turns out to be positive, one, to help themselves, to see what they can do to prevent themselves from going on to develop a disease, as well as to help them prevent the spread of infection by counseling them about how they can prevent the spread among their loved ones, their sexual partners, giving them counseling, for example, if they're women of childbearing age, about the dangers of getting pregnant or what have you.
But you do not propose isolation of people who are either drug addicted or, quote, sexually addicted until they desist from this behavior as a way of controlling the spread of this disease.
That's a different story. You will always find the rare sociopathic individual who's infected and know that they're infected and deliberately goes out and infect other people. But I can tell you from my experience with a large number of AIDS patients and people who are infected with the virus, that is a very, very rare event. If, in fact, you have someone that still persists in doing that, I think then that becomes a judicial problem more than a medical problem.
Thank you.
Any questions? Because I got a couple.
I'll ask some more.
I got some. You got some? Bob, yeah?
I just wanted to.
Use the microphone, please.
I just wanted to follow up on the last question. You answered with respect to isolation of the compulsive. There are actually two questions. One is, what about the contact tracing of people who have found to be have been positive, and information and the breach, if you will, of confidentiality with respect to the sex partners?
Yeah. That is such a complicated issue that even if I were to give you an opinion of what I thought, that there are so many problems associated with that that need to be worked out before you can have a coherent and cohesive policy on that. I mean, when you talk about sexually transmitted diseases, there is precedence of doing contact tracing, but it's almost always in association with a situation where you find a sexual partner, you identify them, you treat them with a shot of penicillin, and you've done them a very great service. You've gotten rid of their gonorrhea, or you've gotten rid of their syphilis. At the present time, that's not the case with HIV, because even though AZT has been shown to prolong the lives of individuals who have serious HIV infection, we're certainly not nearly at the stage, as it were, that we are with penicillin and syphilis or gonorrhea. So that's one issue that's a confounding issue in the answer to your question. The second issue is the whole idea of confidentiality and the protection of persons' rights. It is a very rare event in history that someone finds out that they're positive serology for syphilis and they get a shot of penicillin and they wind up losing their job, their health insurance, and getting their houses burned down. So it's really a different situation when you talk about identifying people who are infected. So although from a medical standpoint, it would be very nice to be able to identify an infected person, counsel them, treat them, or what have you, there are so many other issues that need to be addressed that I don't think I can answer your question and give you a firm recommendation on that. That really is a very much of a multidisciplinary thing to consider.
Well, that was part of the actually that was part of the point, to get that point that it's multidisciplinary on the record.
Right.
The other part of that, though, is that much of the commentary that I've seen on from the multiplicity of disciplines which have commented on this issue is that it is a mistake. Some people say it's a mistake, other people say it's the appropriate way to look at it, to focus purely on the person with HIV, that part of the reason for tracing and or isolation, and when we deal with drug abusers, it's even more clear, I think, than with sexually transmitted HIV, that one of the reasons that you might isolate and or contact trace is to get these people to stop whatever behavior they're doing in order to prevent other people from catching the virus. To what extent epidemiologically, would those types of behavior further the lessening of the spread of the virus?
Probably very little, because once you have a situation where you're testing people and tracing partners, what you will probably do is have an impact on a disincentive or discouraging people from being tested, and then therefore cutting off the tracing of their partners. If someone knows that there is a possible negative component to being tested or to have their sexual partner tested, you will then drive underground the very people that you're trying to bring out and test and counsel. That's a big problem.
Okay, then did you want to follow up on that? Because I have one other question related to the vaccine. Actually, the related points. One is the vaccines won't prevent the transmission of the disease, as I understood it.
Yeah, vaccine does prevent transmission of infection.
Okay, but not, I'm sorry. It would, if somebody
There's
is...
vaccine and their treatment. If you vaccinate someone who's not infected and you have an effective vaccine, when they get exposed, they won't be infected. Vaccine is useless in the classic sense for someone who's already infected.
I see. All right. Okay. And then the other one is, if civil rights protection is key to seropositivity status, then would an effective vaccine, in effect, give you seropositivity status?
Yes, it would. It would give you seropositivity, but it depends on the vaccine that is used. Let me try and make it as simple as I can. If someone gets infected with the virus in the wild state, namely gets it from a contact, their antibodies will show a pattern that will be multiple components of the virus. In fact, if you take the pattern of someone, it looks like this. If this were a Western blot, if someone were infected, they'd have all of these bands being positive. If I vaccinated you with a purified component of the virus, the way we're doing now in Bethesda, the only thing you would have would be these two bands. So I could tell you by definition that you got that positivity by a vaccine and not by getting infected. In fact, to protect the rights of the people in our NIH vaccine program, we are giving them a certificate saying that they, in fact, are a participant in a government-sponsored vaccine trial, and if they want, they can actually get a copy of their Western blot, which would prove that, in fact, that they're not infected.
All right, thank you.
Good question. Dr. Fauci, could you go back to your slide about New York? Is that somewhere not too far away?
Sure. About the babies in New York?
No, about different neighborhoods in New York.
That's the baby slide.
The baby slide. This slide.
Yeah.
How did you get those numbers?
That was a statewide survey that was conducted by the Department of Health of the state of New York, looking at hospitals in various locations as sampling representative hospitals in a variety of locations, including New York City. And that's the result of looking at individuals, for example, in general hospitals in the Bronx versus Manhattan or what have you, and taking a sample of blood, which you take to children anyway when you do a test for a particular metabolic disease on all infants who are born, and applying that to the HIV, and that's how you got that. That was in the front page of the New York Times about 4 months ago.
But now tell me, how confidential is this collection process?
How confidential?
Yeah, I mean, what is the confidentiality mechanism in this process?
Yeah. There were no identifiers in that particular study. In other words, the people who did the test didn't know who they were doing the test on, and if the result was positive, they didn't know. They only were able to develop quantitative numbers. For example, if every baby in the hospital gets a heel stick and blood is put on a paper, and they test it on all the papers, at the end of the week, they say, we have 20 positives. They have no way of identifying who the positives were and were not.
But you have some identifying what the universe is. Of all people that went in the hospital that week, you know how many babies were delivered that week. Therefore, you might know.
Right.
So that might have some, could that be a problem later?
I don't think, in fact, I can't imagine how it could be a problem. There'd be no way of identifying those individual babies.
Okay. I guess my other question is this. Looks like we're in a kind of a race in the treatment of this disease. On the one hand, you're racing to develop vaccine and so forth. Now, on the other hand, there's a race to see if we can interrupt the transmission of this disease. Do you have any idea when those things might come together?
Well, I
mean,
think,
excuse me. Yeah. There are two sides to this public health question. Right. One is the question about what do we do about public health policies other than the ones you operate by, which are to do the research and to obtain the vaccine. Is there any projection when those might come together?
I think that you're starting to see results in both of those areas right now. If you talk about education and risk reduction, there right now is clear-cut evidence that a risk reduction campaign is having very important results. For example, the incidence of new infection among male homosexuals in high-risk cities is very, very low right now compared to 1983 and 1984. It was somewhere 10 or 12 or whatever percent per year. Now it's less than 1% per year among male homosexuals because they are quite well educated now about what they need to do to avoid infection. In addition, we know that the incidence of other sexually transmitted diseases, which is a good indicator of change in sexual behavior and sexual habits, is very, very low among male homosexuals. The incidence of rectal gonorrhea in certain major cities is down by 75 to 85%. That's a very important indicator that this risk reduction public health type policy that you're talking about is already starting to reap benefits. With regard to the basic science, it depends on what you're talking about. If you're talking about drug, as I mentioned, we already have a drug, AZT, which has some benefit. It certainly isn't the cure and it isn't the answer. I would project, though these are just guesstimates, that within the next 2 years, we will probably have other drugs that will be used alone or in combination with AZT, which will have even better results than we're seeing now. And as I mentioned, vaccine is going to lag behind all the others.
And you're saying that the educational efforts among high-risk populations and the counseling is beginning to pay off?
Yes, among certain high-risk populations.
Among certain high-risk populations. Now,
some are more difficult, like the IV drug abuser population.
Now I want to get to that point. Since IV drug users are, in a sense, a more captive or dependent audience on drugs, isn't it much more difficult to reach the IV drug user, and don't we stand a chance of having an increased spread of this of the virus because of IV drug use as opposed to homosexual activity among men?
There's no question that at the present time in 1988, the greater risk of spread into the general population would be through heterosexual contact with IV drug abusing cohorts than from male homosexuals. This is something that has been recognized and addressed by a number of groups, including the President's Commission on AIDS, who made just that statement, that that's a target population that needs to be looked at very carefully. One of the recommended ways to get around the recalcitrance and the difficulty in dealing with IV drug abusers is to implement drug treatment programs, to get them into treatment programs, which would be a very good way to get them away from sharing IV drug needles, which is the spread of HIV.
I guess my final question is that there's been a lot of talk about the allocation of public resources for research and for public health activities. What do you think is an adequate number for adequate allocation at a federal level, at least, for this? I realize that most of this is a local response, but how much money is needed?
Well, you try to make a best estimate based on the state of art, for example, in research, and I can only speak to the research area, the state of the art, the number of individuals who can and will be working in this area, and I can say that from the National Institutes of Health standpoint, that the amount that is being proposed for the 1989 budget, I believe, is an adequate amount. It's $587 million, $588 million, which I believe from a research standpoint is enough to do the job that we have to do.
I guess my final question is this. If we don't spend the 587 or some other number or something, then how much do we lose on the other end in terms of lost productivity from people who can't go to work and who need transfer payments or Medicaid to make sure their conditions, they can be cared for? What would you estimate the loss to be if we didn't spend this kind of money? Do you have an idea at all?
It's wide ranges of estimates of how much, for example, by 1990, when you expect to have a cumulative number of 270,000 cases in the United States, the number varies with a great margin of error, but certainly it's measured in health care costs and other costs of well into the $20 to $50 billion. It's going to be a lot of money.
Okay. Any other questions from panelists?
Yes, Bambi's got one. Let me ask him, follow up on that slide.
Go ahead.
Question real quick.
Mr. Chairman.
Dr. Fauci?
Excuse me, Mr. Chairman, I was diverted. Could I hear that last thing again?
Somewhere between 20 and $50 billion of all healthcare costs, lost productivity, and those are very, very rough estimates by the year 1990. If we have 270,000 people cumulative who develop, but that's a number that's not a surprise. This has been kicked around and discussed in many fora.
How many would still be alive that would be costing this money? Because you say 270,000
Yeah.
cumulative,
Right.
but how
About half of them probably will have been dead by,
by that time? Yeah. it's only
It'd be-
half.
I'm talking about in terms of lost productivity. That is, these
I
are
can't give
people-
you a number on that.
Yeah, but these are people that can't go to work.
Right, sure.
Who are dependent for,
Right.
primarily for the public, for their health care and the like, so there's a productivity loss that way.
Sure, I don't have a solid number for you on that.
You got a
Just
question?
have a point of clarification on that slide. Was that survey taken of all hospitals in the city or just public? Was it
Just public
and-
hospitals.
It was just public.
Yeah, right.
Yes, go ahead,
Commissioner
Francis.
Ramirez, I'm sorry.
Why don't I if this is a follow-up question, why don't you go ahead?
Well, it's on the question of the incidence of the HIV transmission being attendant to the intravenous drug user. I'm understanding you to say that we anticipate the primary source of transmission between now and 1990 is going to be from that population.
Transmission, I didn't say primary, I'm saying that it's going to be a major source.
What would be, in your prognosis, the primary source?
Again, I think you're going to still see a degree of homosexual contact, probably less and less as the years go by, and I think you're going to be seeing an increase in IV drug abuse and heterosexual contact that's secondary to the IV drug abuse, namely someone who's the lover of an IV drug abuser. You're going to seeing an increase in infants who are born of infected mothers who are either IV drug abusers or who are the sexual partners of IV drug abusers. So I think it would be correct to say that given the decrease in spread of infection, not disease, because disease, it's still going to be male homosexuals, because in 1990, the people who are going to get disease are going to be the people who were infected 5-6 years before. So you're still going to see an increase among male homosexuals for disease, but new infections, you're going to see a shift over towards the IV drug abusing population as the predominant group.
So that's
Sorry.
okay.
Go ahead, Mr. Guest.
Is it safe for me to conclude then that as a matter of public policy, there should be a correlation between this country's inability to hamper the importation of illegal drugs as well as the health effects it's having in terms of the transmission of AIDS?
Well, I don't know if I can answer that because I don't know what the level, the relationship between hampering the importing of drugs and use, et cetera. That's in a different area of expertise than mine. I think if you cut down IV drug abuse, you certainly will cut down transmissibility of infection. Whether stopping drugs at the border is the answer is something that's not in my line of expertise. But certainly if you stop IV drug abuse, you're going to stop transmissibility of the virus.
Commissioner Ramirez?
Let me just try to restate the context from my questions. We, on the Commission, obviously have a civil rights rather than a public health function. And it is very difficult for us to continue to focus on civil rights concerns when there is so much that needs to be understood about the public health concerns. But I am interested first, so I'm violating my own rule in asking you a question which has more to do with perhaps a public health issue. And I would like to know whether, in terms of your understanding of the transmissibility, the method of transmission question has been resolved, or rather, do you anticipate that it is likely that there would be any other methods of transmission that would come out of research? Is there research being done? Do you understand my question?
I understand the question, and the question is that the amount of data that has confirmed the three major methods of transmissibility, which I mentioned, blood products, sex, and mother to child, is overwhelmingly large amount of data. On the other hand, the amount of data collected to indicate that casual contact is not a form of transmissibility is also rather compelling data. So scientifically, we certainly don't anticipate that we're going to all of a sudden come up with a new way the virus is transmitted that we haven't recognized up to now. You're going to see a fluke case in a 1 in a million somewhere, someplace, and that always happens in biology. Nothing is 100%. But I don't think there's any chance you're going to see a major revelation about a new way that the virus is transmitted.
I'm sorry.
Our focus on civil rights, and indeed our reason for holding these hearings in part, have to do with the fact that up to this point, the populations which were infected or who surfaced with the problem of AIDS and HIV infection, are populations that have themselves over the years been victims of discriminatory practices and have themselves who continue to operate in the society with a predisposition to bias against those populations. Do you believe that, and this may be out of your area of expertise, that reality of having these less desirable, if you would, in historically less desirable populations being the object of this disease, does that in any way affect the way in which public health strategies are implemented or are viewed in terms of trying to resolve the public health issue?
In my opinion, absolutely not. I've been working on the AIDS problem since the summer of '81 when it was first recognized as a researcher and a public health official, and I could say never once in all of the years that we've been working on it at the level of research, public health, or what have you, has the fact that the major group that's infected in this country, male homosexuals or IV drug abusers, influenced the direction of research or a public health opinion or policy or what have you.
One other question, actually two other questions. One, when we talk about... Yes, I'm trying to be fast.
Okay.
When we talk about HIV drug users, is the transmission of the disease significantly more prevalent among low-income minority HIV drug users, or is it found among all of the IV drug user population?
Well, the only handle that one has on the IV drug abusing population in this country indicates that they are predominantly minorities, blacks and Hispanics in this country. Whether or not you'll have an upper middle class person who's shooting heroin that they're buying at the top of the drawer highest prices, no one even knows about them. The ones you know about are the ones that get arrested, the ones that you see in the streets, the one that go to the clinic, and most of those, the majority of those, are of the lower socioeconomic group and are minorities. So in fact they are suffering unduly from both the drug abusing problem and HIV among drug abusers.
I would just submit, Commissioner Ramirez, that people that are drug users are not necessarily low-income people.
Well, that was my point. But obviously...
No, I mean, but those that consider to be low-income are not really low-income because you can't really have a habit if you have low income.
But it's the needles, it's the use of infected needles that is the issue. And obviously, if you can afford to buy clean needles...
If you're sharing a needle in a shooting gallery in the South Bronx, there's the greater chance of you're getting infected with HIV than if you're on 73rd Street and Lexington Avenue in an apartment shooting up by yourself with a needle that you got from a physician that's clean, of course.
Commissioner Buckley,
Well,
we have to...
I'd like to go back to that one, and these are May the 2nd, 1988 CDC statistics, and of IV drug abusers that have been identified, 6% were white, 37 were black, 38 were Hispanic. And you might be able just to look at that and determine that it may not be the low income that's the factor in this case. It may be the shooting gallery situation that would be involved. I'd like to come back to what she was saying. The public health issue is very interesting, and the scientific aspects of this is, of course, I mean, we could spend a lot of time on it, but what I'd like to do is come back to the civil rights aspect of this. And from what I keep hearing, it's like if the general public were to know more about the disease, about the progress, about the latency period and the transmissibility of it, do you think that if we continue massive educational programs that we can control it to where the discrimination aspect associated with AIDS could be controlled without requiring going into a legislative activity at this point? Do you think we could, keep discrimination out of the picture and deal with a public health issue first if we were to continue with education? And then what educational programs would you advocate from different government agencies, of course?
I don't think there's any question that the more education that you have, the greater people will understand the illness and the infection, and the more they understand it, I think you will see a lessening of discrimination. I don't know, and I don't think I'm qualified to answer whether or not education of the American public is going to eliminate discrimination. From what I know of my experience in life, it probably will not eliminate discrimination. But nonetheless, I think it will help. And one of the things that you're going to be seeing soon is the mailing to all of the households in the United States, the brochure on AIDS. It's going to be over 100 million mailings that are going to go out. And I think if people read that brochure, they'll learn a lot about what's going on and how it can and cannot be transmitted, and about what it means to be infected. I think that will help against discrimination.
One question from council, and then Commissioner Berry has a brief question. Go ahead.
Clarification and question. The percentage breakdown, you had 4% for heterosexual transmission.
Right.
Does that not include 2% heterosexual contact and about 2% born in nations where heterosexual transmission is thought to be the prime?
Yes, it does.
In other words, Haiti and Central Africa.
But it's almost certain that those are heterosexual contact from our epidemiological surveys, both in Central Africa and in Port-au-Prince in Haiti.
Okay. Now, my question, Dr. Fauci, concerns you and Jeff Levy in a previous panel talked about education as having shown having resulted in a marked decrease in new infections in the homosexual community. About what year do you think that education really kicked in enough to make a difference?
Well, probably around 1986, I would think. 86 and 8. If you look at the curve of new infections in San Francisco, you have new infections of seroconversions in 82, 83, and 84, and 85, and then right after that it starts to come down, 86, 87, and 88. And it's a combination of the fact that when the virus was recognized as being the cause of AIDS, that people were convinced that they had a transmissible agent here that you could avoid by behavioral change. There was a lot of, I think, wishful thinking in the community then that it wasn't an infectious agent. And then when it became very clear that it was, and that word was being spread by the gay groups among themselves, that they began to change the level of high-risk behavior.
Okay, well, the data I have here is somewhat confusing. What I have here is Table 12 from a November 30th report that was sent to the commissioners in their first mailing. I'll show the cover so they know what I'm talking about.
Okay.
Okay, according to Table 12, and I assume this is where you're getting your information from. These are cohort studies done from around the country. There are two from San Francisco that show blood being tested as early as 1978 all the way up to the present. And it shows what you're talking about. It shows every year it goes up a little more, and then it really goes up, and then it declines rapidly. Problem, Dr. Fauci, is that the peak in the main San Francisco study, the one with the most individuals and the one that went all the way back to 1978, it goes 1980, 11% seroconverted, became HIV positive. 1981, 14.8% became seropositive. 1982, 20.8% of the cohort became seropositive. But in 1983, it dropped to 2.1%. In 1984, 2.1. In 1985, 2.1. And now it's gone down even lower. In other words, about 4 years before you said education kicked in, it seems like there was a tremendous drop-off. And the other studies seem to show this too. There was, it seems that they might have hit a saturation point before that. Do you see my point?
Sure.
Is that correlative with
you always have to
education
balance the
having done
possibility that you're saturating the population, and that's why you're not getting new cases. You also have to factor in that even though the agent was not identified then, there was a great suspicion among us that there was an infectious agent. We were laboring under the presumption that it was an infectious agent for several years before. So I think your figures are making it earlier than I had said. I didn't have the numbers in front of me, but there's probably an awareness of the fact that it is very likely that this is an infectious agent combined with a saturation factor. I don't think there's any question that there's a saturation factor there.
So perhaps the education aspect has been somewhat overplayed in showing the greatly reduced incidences.
Well, no, let me give you some other data that says it isn't overplayed, and that is that if you look at the incidence of rectal gonorrhea in sexually transmitted disease clinics and compare it 83, 84, and then 85, 86, and 87, you have anywhere from a 75 to an 80% decrease in rectal gonorrhea, which is telling you that risk behavior of rectal intercourse or unprotected rectal intercourse clearly has to be going down. It's a good proxy indicator of sexual activity that's a high-risk activity. So I think your point about saturation is true with regard to HIV. It has to play some role, the extent to which I'm not certain, but it doesn't tell you anything at all about rectal gonorrhea. Rectal gonorrhea decrease is clearly a behavioral change.
Thank you.
Right.
Commissioner Berry?
Dr. Fauci, you said it was all right to ask you questions about controlling use of drugs as opposed to drugs coming in the country, so I'll ask you about that. Do you think that clean needle programs help in terms of keeping down the transmission of HIV through the needles that the addicts use, and do you support such programs?
That's something that's actually being looked at very carefully now about trying to get information from the programs that are already existing, for example, in England and in other areas, as to whether or not that has any negative effect on people's drug abuse, namely, do they abuse drugs more or do they abuse drugs the same or less? So I think it's something that at least should be considered in investigating the data that's already available. And if it looks like there may be a situation where it could be helpful, I think it would be worthwhile in a pilot project. That's not government policy I'm talking to you, and I'm not speaking now as the policy of the Public Health Service, but I think we should at least look at the data that's being accumulated from the programs that are already going. It might turn out to be a good thing. I don't know that right now.
Are you also looking at decriminalization as a means for encouraging people seeking treatment and therefore indirectly having some influence on transmissibility?
No, I'm not. I have enough things to do without worrying about decriminalization.
Not you personally, but I mean as a Public Health Service, to your knowledge.
No, the Public Health Service is not involved in it. They're mostly
You're not
involved
looking at that.
in the public health components and not the legal components.
And finally, Mr. Chairman, the issue of money for research. You said something like $589 million.
588. Right.
Proposed for FY what, 89?
Fiscal year 89 for the National Institutes of Health.
Research.
For research. $1.3 billion for the Public Health Service.
And you said that you thought that that was sufficient money, if I understood you correctly.
Yes.
And since you're one of the few public officials or researchers who I've ever heard say that there was sufficient money, are you saying that because, indeed, the capacity to use the money,
that's it,
that there wouldn't be enough research projects that you could fund that would make any contribution to this, that it's just not possible to use it, or what is the basis
No,
of
I
your...
think if you ask any researcher, and I also am a researcher myself in addition to administering science, you will always be able to come up with someone asking for more that they think they could do a little bit more. You've got to make some sort of a reasonable estimate based on what you think can be done with the money that's available, and based on the kinds of ad hoc groups we brought together to see what is the pool of investigator out there, what are the projects that are ready to be done. That figure is about the right ballpark. I'm sure someone is going to come up during the fiscal year that we're talking about with projects that actually might need more money. And that's when you reconsider it with either amendments or at the time it won't be an amendment, it'll be a supplement. Right.
And really, finally, Mr. Chairman, would you support a proposal to have us fund as taxpayers through our budget research proposals, even if they were from researchers from abroad who were in other countries, as a way, and to do that systematically, wherever they are throughout the world, to the extent that they have proposals, as just a matter of policy? What are we doing about that, and would you support extending an effort in that regard?
That's easy, because in fact, it is a policy of the National Institutes of Health that we will fund research proposals from foreign investigators in foreign countries if, in fact, it's clear that there's a level of expertise in that particular area that it can be done better by them as opposed to a researcher in the United States. If you have a